called Defining ARDS, and with our usual assortment of panelists, Professor Banguti, Ali Barata, Dr. Honorine, Dr. Jackson, and Dr. Francois Uwimana. And so I will pass it on to Professor Banguti to get us started.
Hello, good afternoon. Are you hearing me?
Yeah, good afternoon. Yes, we hear you.
So today it is the session number 7, which is about defining ARDS. And most of the elements to be discussed today have been discussed in other sessions previously, from session 1 to 6, as you can see. Next slide, please. Yes, as you can see, the session is about defining ARDS. We will together discuss about ARDS and discuss it. Then we will discuss about ARDS and the respiratory failure. That we will discuss about the Berlin definition of ARDS. We'll present it to you, and it will be interactive, so we can have some questions about it. Then come to the Kigali modification of Berlin definition, which I always insist to all people attending sessions where we talk about Kigali and say that is our pride. So we expect everyone to know what has been defined in Kigali. What is the contribution of some of the Rwandan colleagues and experts to the definition of ARDS. After that, we will go to there is another COVID-19 consideration of ARDS. So as COVID is coming, is issuing, we are having other considerations. Pandemic, there will be a COVID modification for ARDS definition. So the longer session will be on management of ARDS. So next session, please. Today will be a case-based discussion. This patient has been discussed in the session number 6 with a 46 years old patient who is hypoxemic with respiratory distress. The patient has been found positive on COVID, and his clinical course progressed to respiratory failure, requiring ICU admission, intubation, and mechanical ventilation. Remember, in session number 6, this patient was not in ICU, was to be admitted and be transported and admitted. So now he's in ICU, already intubated and ventilated. The vitals are down. The heart rate is 102. The blood pressure is borderline. Respiratory rate is 35. Temperature 7.5 Celsius. SpO2 is 90%. So he's on mechanical ventilation, accelerated control and volume control. And the FiO2 is 100%. Respiratory rate 35. The tidal volume is 400 and PEEP 14. In the chat, please, can you comment on this patient? In the chat, please, colleague, attendant, can you comment a little bit? How do you find this patient? Is he a septic patient? Is the patient in shock? Is the patient hypoxic? Why do you say that? Is he severely hypoxic? So what is the PEEP of 14? What does it mean to you? So I would like to see some of your comments before continuing our session. Please use the chat to make some comments so that feel free to use the chat. Any comment on this patient with respiratory rate of 100, blood pressure of 97, SpO2 is 90% on an FiO2 of 100. I can't see any chat. So no reaction at all. And yet we have 55, 56 people. Oh, thank you very much. I can see people now are coming. Okay, good. So he's hypoxic. The PIP means poor lung compliance. Yeah, hello, the patient is in shock. I don't get the question. Oh, he's hypoxic. Patient is hypoxic and IR settings, that's good. He's hypoxemic. As he has 90 FiO2, people 14. Yeah, those are quite encouraging answers. So it means we are discussing, we are talking to an audience. People are really having some good level, and so we can set up our level of teaching. Feel free to keep giving some answers. We have a good panel. People will keep recording your question or comment. Next slide, please. So among the expected practice change objectives, this is coming from the Learning Resource Center, and I'm sure you all have the link to that Learning Resource Center. And please make sure you visit that center sometimes, as you can learn a lot. So we're expecting people by the end of the session to learn and change some practice, understand, to define respiratory failure. What is respiratory failure? Especially what is the difference between respiratory failure and respiratory distress? Put it down on a paper. By the end of the session, if it doesn't come clearly, feel free to remind and to re-ask the question. We need to know different type of respiratory failure. Again, hypoxia will come back. What is hypoxemia? What is the definition of hypoxemia? Using the pulse oximeter and also using the blood gas. We'll also have the ARDS, four key criteria of ARDS. And we will apply the Kigali modification, the diagnosis of ARDS, the Berlin definition, and also the Kigali modification. Also, we will discuss a little bit the pathophysiology of ARDS before going to the management. So in the management, there is a lot. It can even make a book of management of ARDS, but we'll just pick up a few principles like the lung protective ventilation, parameter to use for improving oxygenation, for improving CO2, and appropriate intervention known to improve oxygenation in ARDS patient. So those are the few expectations we have for this session. Next slide, please. So ARDS was first defined or described in 1967. Then after, in 1994, this American European Consensus Conference defined at Berlin, met at Berlin, Germany, and defined ARDS with the four criteria, the four key criteria of definition. We will discuss on it. Then recently, in Kigali, a team of experts did a research and came up with a modification of the Berlin definition. They started from Kigali, but after some application and conferences, people found it very relevant to be used, as it has benefit, it add on some benefit to include some patients who were left behind before. You will hear about that during the presentation. Nowadays, we are facing COVID-19, and it is an ARDS-like pathology. So we have some considerations. So to make it simple, because medicine is so vast, you need to make some tricks to make things easy so you can know, you can easily define everything. So we are working on the 7 P's steering for ARDS management. So the 7 P's, 1 P is for population, 1 for pathophysiology, another 1 for perfusion and ventilation impairments, prevention of protective lung ventilation, positioning, the prone positioning, protocol for weaning, and also prevention of complication. So those are the 7 P's we use as a framework in our department to make ARDS easy for everyone, especially when we're teaching such complex knowledge to younger residents. We make it simple with 7 P's. So in the pathophysiology, you know, it starts by a lung injury. Remember, there is some discussion about what is the difference between acute lung injury and ARDS, because those two sometimes are very confusing. So there is many causes of lung injury. It can be transfusion-related lung injury, which is called TRALI. It can be trauma-related lung injury, which can be, it's also TRALI. It can be, or it can be TRALI because it is trauma-induced lung injury. It can be ventilator-induced lung injury, VELI, or ventilator-associated lung injury, VALI. There is many causes of lung injury. Those can be acute and in short time, or it can perdure and stay for long, which end up to become an ARDS. So then we'll see you need to meet the 4 criteria to be called ARDS. If you don't meet the 4 criteria, then you are still in acute lung injury. So after the lung injury, there is increasing in alveolo-capillary membrane permeabilities, which will cause edema and interstitial and intra-alveolar edema to the interstitial and the intra-alveolar, which will impair the oxygen diffusion and oxygen gas exchange. It will decrease the surfactants, which means the compliance will be reduced, compliance of the alveolar. It will cause atelectasis, which is collapse of the alveolars, and decreased gas exchange. When you have those 3 aligned, decrease of compliance of the alveolars and the lungs, atelectasis, and decrease in gas exchange, we end up into shunt, which is increase of shunt will cause hypoxemia and increase of work of breath. Then you fell up into a distress, respiratory distress, which is the definition, acute respiratory distress syndrome, or even into respiratory failure. Next slide, please. So the question is, what is the difference between respiratory failure and respiratory distress? So our colleague Honorine will help us on this. Honorine?
Hello. I want to hear from the participant what are different between respiratory failure and respiratory distress. So you can answer by chatting. Hello. What is the difference between respiratory failure and respiratory distress? Hello? Okay, if there is no answer, we can go to the next slide. By definition, respiratory distress is an acute onset of increased in work of breathing that may be characterized by increased in respiratory rate. The rate is increased because the patient is trying to get more oxygen. The patient may present with grunting. Thank you for answering. The patient may present with grunting. Grunting means it's a noise that comes when the patient is trying to make airway patterns. Nasopharynx, it's a kind of nostril movement that is showing the patient is using much effort to get air in lungs. Retraction, it's also a sign of that patient is using much effort to breathe. It may happen subcostal, below of ribs, and it can happen in through in the intercostal muscles, substernal part, and the suprasternal part. The patient may present with wheezing, but not always, depending on the condition that causes that respiratory distress. It most happen in obstructing airway lung disease. Tripod position. It's a position by which the patient lean forward to get more intrathoracic space, then he or she can get much air in lungs. Next slide. So respiratory failure is the loss of ability to ventilate adequately or to provide enough oxygen to the blood and to the systemic organ. It has 4 types. The first type is called hypoxemic one. This is when the arterial oxygen partial pressure is less than 60. It means there is low oxygen in blood circulation. That may be second to main causes. So depending on the lung disease. The type 2 is hypercarbic one, when the patient failed to move out the CO2, and then the CO2 will be increased much more greater than 6 millimeters of mercury. Here, the patient most of the time is present with obstructive lung disease that's prevent him or her to exhale the CO2. Perioperative or respiratory failure. It's a kind of hypoxemic one. It happens most during or post-surgery, and where the patient become hypoxic, depending on the type of surgery happening or the way the patient have been ventilated during operation. The last one is a shock. Shock, it comes because of instability of hemodynamics. It means here the patient may have with shock. There is not much blood in lungs for gas exchange, so the patient will underwent metabolization in the body, but there will be no exchange of CO2 and the oxygen to the lung because no blood to the lungs. So the patient will be failing to provide the adequate oxygen to the blood and the organs. We will learn more about respiratory distress and failure in a discussion. So can we go to the next slide? There are different causes of respiratory failure. So respiratory failure, as we saw, it's from two things: loss of ability of ventilation and the ability of getting oxygen. The ability of getting oxygen, most of the time it comes from the lung fail. The lung tissues fail to allow the gas exchange that lead to hypoxemia. This is what that diagram is showing for the first law. The secondary, there is a fail of ventilation, fail of pump fail. The patient failed to inspire and expire the CO2. So this may be secondary to central depression. Central depression, it means when the patient has a problem in brain that affects the cardiorespiratory center, like when the patient had brain edema, may have herniation, then the medulla loss functions, or the patient with trauma brain injury. There are so many causes of central depression due to that lead to failure of ventilation. Another one may be mechanical defect. Mechanical defect may be due to foreign body that prevent patient to inhale or exhale the air, or from obstruct or bronchoconstrictions, like in asthma, the patient failed to pump in and out the air. And also fatigue is the cause because the patient it starts with increasing respiratory rate, tachypnea, as the patient is breathing rapidly. At a certain time, there is fatigue, tiredness, so the patient with tiredness will fail to ventilate properly. I think this is the last slide. The next person may continue. Thank you.
Thank you so much, Dr. Honorine. This is the talk about the Berlin definition, and we will keep going with our case. Maybe some participant came in later. Let's repeat it a little bit. This is Mr. T, 46 years old male, who was hypoxemic with respiratory distress. The patient has been found positive on SARS-CoV-2 and his clinical course progressed to respiratory failure. And this required ICU admission, intubation, and mechanical ventilation was initiated. The vitals and mechanical ventilator settings are as follows. The heart rate was 102, the blood pressure was 97/51, respiratory rate was 35, temperature of 37.5 degrees Celsius. The SpO2 was 90%. On mechanical vent, the settings was as follow. The patient was on AC mode. The FiO2 was set at 100%. The respiratory rate was still 35. The tidal volume of 400. The PEEP was 14. The peak pressure was 40. So this is a case which we'll be using to understand where the definition, the Berlin definition of ARDS. Next slide. The question from the previous slide, the question was asking if the patient is having ARDS. Excuse me, can you go to previous? Can you go to previous slide, please? Okay, thank you. So the patients here, we have those vital signs and the ventilator signs. The question is asking if this patient is having ARDS. Who can guess? Let's use like 1 minute for chatting. Who can guess? Does the patient has ARDS? No reaction? Okay, let's go to criteria of ARDS according to Berlin definition. As a prof, yes to honest, maybe we will discuss and know why. Thank you for responding. So as prof said, the ARDS has been defined several times in the past, and the Berlin definition was elaborated in 2012, and it set like 4 criteria to be considered when we say that we need other findings to conclude. Yes, thank you. That's true. This is why we are going to discuss the criteria. Thank you so much, Christian. So we have in front of us timing some criteria, as Christian is saying. He's saying that we need other data to confirm if the patient is having ARDS. So ARDS has been defined several times since 1967, as Prof was saying. And the Berlin definition we are talking about was defined in 2012. And it set like 4 criteria to be considered when we want to say that this patient, even if he's having respiratory failure, as was defined by Dr. Honorine, but he is having ARDS. So the first area is timing. We need to know when the respiratory failure started. So according to Berlin definition, this worsening respiratory failure so much. The first criteria we're saying it is timing. The timing, if the worsening respiratory failure happened 1 week after the lung insult, we have to consider that as a first criteria for the patient. Then the next one is hypoxemia. Hypoxemia, for Berlin definition, they used the ratio of PaO2 and FiO2, where they classified or they categorized the hypoxemia into 3 categories: the mild, the moderate, and the severe hypoxemia. So for mild hypoxemia, the patient should have a ratio of PaO2 to FiO2, which is between 201 to 300 millimeter of mercury, with a PEEP or CPAP, which is over 5 centimeters of water. Then for the moderate, this range, the ratio should be below or equal to 200 millimeter of mercury, with a PEEP which is over 5 centimeters of water. For the severe one, the PaO2 or the ratio of PaO2 and FiO2 should be below 100 millimeter of mercury, with a PEEP or CPAP which is over 10 centimeters of water. So this is the criteria for hypoxemia. So now the origin of edema, it should be exclude any origin for cardiac failure or any fluid overload. Then on the X-ray, the X-ray abnormalities should always show the bilateral opacities if we are interpreting the X-ray for this particular patients. As Christia was saying that we are missing other data for confirming. From the previous data, we only have the data on vital signs and the mechanical vent settings, but we don't have when the respiratory failure started for that particular patient, or if the patient is having pulmonary edema, or X-ray for this patient. Can we go to the next slide, please? So now we need to understand where the keywords from the Berlin definition, so that so that we'll be able to assess and confirm for our patient. So we've been saying the ratio of PaO2, FiO2. So what is a PaO2? From the audience, what is PaO2? Previous, so that we hide it bit. Previous slide, please. Okay, what is PaO2 from the audience? What is PaO2? For us to be able to do this ratio, partial arterial oxygen saturation. It's not saturation, it's pressure. PaO2, it's pressure. O2 within the artery, it's a pressure of O2, arterial pressure of oxygen. Thank you so much. This is a real response from Murunziza Pacific. To be quick, what is FiO2? Partial pressure of oxygen in artery. Thank you, Maurice. To be quick, what is FiO2? FiO2. What is it? Rules, what is FiO2? What is fraction of inspired oxygen? Thank you so much. Fraction of inspired oxygen. Thank you so much. So how much should it be at room air? How much should it be at room air? Thank you, Theogene, thank you. How much should it be? 21%, perfect. So thank you. Thank you so much. So just another question to you. How much, thank you all of you, the PaO2, if we are saying the PaO2 of the ratio of PaO2 and the FiO2, what should be the normal range for a normal person? How much should be the ratio for no? Oh my goodness, 2001, 152, no. For this particular question, let's reserve it for the breakout session where we will calculate and confirm to ourselves before thinking of for our patient. We will calculate it for ourselves. Next slide, please. More than 350, yes, this is around the real response. Thank you so much. We'll calculate it and come up with the real response, the real range. So for this Berlin definition, some challenges have was ruled out. They were ruled out. This is why the Kigali modification of Berlin definition was thought about, as a Prophet was saying. One of the challenges was the X-ray. If we need to say that the patient should be having bilateral opacities, like in a, so I think the details will be given by the next presenter. The PEEP, the left ventricular dysfunction to rule out the cause of pulmonary edema from the left ventricular dysfunction. I think then this is going to be well discussed by the next presenter, who is Dr. Jackson. And the breakout session will take us to the calculation we will do some exercise about the calculation of PaO2, FiO2 ratio to make sure that we will really understand when we will be applying it to our real patients. Thank you. The floor is for Dr. Jackson.
Next, right? Hello.
Hello.
Attendees, thank you for having me on board. We are going to discuss the Kigali modification of variant definition of ARDS. And I can't start this presentation without telling Muslims to have their Happy Eid Mubarak, even though it's red. So with Libere who presented about ARDS, now we are going to see why the Kigali modification. How can we now estimate hypoxia in settings where there are no ABGs? Like Kibogora Hospital, where there are no ABGs. How can we now, if our patient is hypoxic, I will need to have some answers from the chat. How can we estimate hypoxia of a patient whom we meet at Kibogora or somewhere, another hospital where there are no ABGs being done? Here I can see some answers. Cyanosis. We can use SpO2. Thank you so much. Oh, by considering SpO2 reading, that's very great. Capnography. I think it can't work. Yes, using pulse oximeter. And this is the very gold principle of this presentation with the oxygen series. A very high respiratory rate can give you a hint on hypoxia. We shall see that. So let's continue with the bearing definition of ARDS. Remember, there are some mechanisms for identifying ARDS which were left behind in case you are in a setting where there are no ABGs being done. And remember, we can rely, there were Dr. Libere echoed about having partial pressure of oxygen over FiO2 ratio, which is done in case you have an ABG, but this time we are going to use SpO2 over FiO2 ratio. And then later on, we call upon the use of ultrasound in ICU, which is a new application, but very, very important. And remember, lung ultrasound may give you an acute alternative to chest radiography in case you do not have it. There are some ICUs which do not have mobile chest imaging machine. So this will give us a hint. So next slide. So the challenges which led to just thinking about Kigali modification were that the technology that is behind finding ARDS in people who have lung infection or edema. So the first thing was technology, where people do not have X-ray machine being mobile to move to ICU. And then there is new techniques of just lung imaging using ultrasound, vagarization of focus. And then the second point was just the use of or estimation of hypoxia using pulse oximetry with SpO2 and FiO2 or oxygen flow that we are currently using in the case of COVID patients. The way the patient needs much oxygen to come in so that they can just try to reduce the work of breathing. And this just coming in will give us a hint on why we need Kigali modification. And then non-cardiogenic edema, which was being determined by having the pulmonary with capillary pressure by inserting these devices via invasive devices to measure the pulmonary with capillary pressure, just giving a hint on the left atrial pressure and left ventricular function. And then this currently is being discouraged. It is invasive and can give much complication and side effects coming from this technique. And that's the reason why moving to the Kigali modification was thought. Next slide. So here comes what we can look in the settings where you do not have an ABG machine being used, where you do not have a mobile X-ray machine to be moved to ICU, or the difficulties of moving a very unstable patient, hypoxic patient to X-ray machine, which is not mobile. So timing, the same as the bearing definition, just within 1 week of a known clinical insult or new or worsening respiratory symptoms, in case you have a patient with respiratory distress or pending respiratory failure, as Dr. Honorin described. And then how do we assess oxygenation? It's now a ratio of SpO2 over FiO2, which is less than 315. And remember, do not ask me about that just grading or severity of hypoxia that the patient may have. In this situation, they just estimated this ratio being below 315. PEEP requirements, remember, you may not have the machine and for ventilating your patient, but being at maybe Munini, far in south of Rwanda, where you do not have machines for ventilating patients. So in that case, you will not refer to PEEP. And then imaging, remember I told you in this case, we will use lung ultrasound, which will give us bilateral opacities, which are not fully explained by effusions, ROBA, or lung collapse, not by chest radiograph. Or in case you do not have an ultrasound, you may have a radiograph, but you take care in case you do not have sufficient oxygen to move your patient from ICU to somewhere else, to the X-ray machine room. Origin of edema, remember this respiratory failure is not fully explained by cardiac failure or fluid overload, and then or any other objective assessments like echocardiogram to exclude hydrostatic risk factor in case they are present. Next slide. So this is the comparison that we may do in the case of bearing and Kigali modification. As you can see, the very marked point will be oxygenation, and then the second point will be on PEEP requirements. Remember, on bearing definition, we need a minimum of 5 centimeters of water PEEP, which is required in the case you are doing invasive mechanical ventilation. And then remember, you may also have patients who do have ARDS, not yet on mechanical ventilation. So with Kigali modification, you can detect all these fraction of patients who were left out with this definition in resource constraint settings. So the other things will be just the POCUS involvement that were brought in to reveal that you may have bilateral infiltrate, or what we call B lines, more than 3 B lines on lung ultrasound, which are showing that your lungs are being flooded. This flooding of the lungs and then not being explained by cardiac origin or just nodules or everything that's led to hydrostatic edema if there are no risk factors. Next slide. What is the trend now in our situation in case we have like this COVID pandemic all over the world? There should be something coming in, like if someone is at Kibuye, where we currently have patients on mechanical ventilation, and then how will I estimate, or Munini, where we do not have machines, but we still need to treat or care about patients with the COVID-19 positive tests and being on oxygen. So now here, just testing their respiratory failure and just their hypoxia will require to assess your patients, and then assessment and the requirement of oxygen flow. Here, in the case of COVID and ARDS associated with COVID, what we give you a hint on ARDS, with their respiratory rates more than 30 per minute, you have lung infiltration, and then this ratio should be low. But remember, the requirements, just required flow of oxygen will give you a hint on how this COVID, the ARDS from COVID is such severe. Remember, the high flow will give you a hint that your patient is being having either asymptomatic mild COVID or moderate, and then later on severe. Then critical COVID patient with ARDS may have respiratory failure symptoms that Dr. Honorin described. And then remember, when it goes to any organ involvement, you may have a shock and multi-organ dysfunction. Any questions so far? So if you have question, go via the chat and then text it. We shall just respond to it. And remember, in the breakout session, we shall just dig into the criteria for Kigali modification of Berlin ARDS definition. Thank you. Next presentation will be management by Dr. Xavier.
Thanks to all presenters, and thank you for the audience. We are going to talk about ARDS management after you understand the definition, the Berlin, the Kigali criteria for something, the Kigali modification comes to challenge the Berlin to the because of settings. One important part of mechanical ventilation, which I think is not available in most of our settings where our audience is coming from. We are having more than 85 participants. I don't know whoever is interested can come to our hospitals, most in Nyarugenge, we're talking about COVID, for a study tour. Next, please. I think the audience have understood what is ARDS, and now Dr. Jackson introduced COVID-19. I have some comment about the first one compared to what you learn about ARDS. Just 1 minute to compare. I need you from the chat, please. COVID-associated ARDS. So from what we learned, the ARDS with all definitions you had, we are going to manage with the problems of reduced lung compliance and the loss of lung volume. According to the pathophysiology we learned in the second slide, we had that with those kind of inflammatory whatever, the lung compliance reduced and then alveoli also and the lung volume is lost. This which is leading also to the problem of impaired oxygenation. And this impaired oxygenation will require the management to be the ventilation after failing the high flow, as Dr. Jackson was saying, with the comparison into the PF ratio or SF ratio in our Kigali conception. This also may lead to high mortality, so that to reduce this high mortality, we need to work in consensus with some adjuvant therapy. And with these 5 components putting it together, we may have this kind of the second X-ray after 2 days the patient has been on mechanical ventilator. With the settings, we are going to talk about lung protective ventilation strategies, which we are going to talk in below the following slides. Next, please. So as we have the case above, whom we needed to decrease the high mortality by the lung protective ventilation strategies. If you see on this mechanical ventilator settings we had in the case, we are having FiO2 of 100. What does this mean? We are having respiratory rate of 35. Why? The respiratory rate of 35, whether we know the normal respiratory rate is in 12 and 20 breaths per minute, tidal volume of 400 and the PEEP of 14, whereas we know the normal should be, I mean, for normal conditions, not this kind of ARDS below 14. So we have to discuss about this lung protective ventilation strategies to help this patient we have in ARDS by understanding what is the rationale behind these strategies. The rationale, it was due to the understanding of ventilator-induced lung injury, as discussed or introduced by Prof in the previous slide. Also with the goal to provide adequate oxygen excretion, known as ventilation usually, and oxygen saturation to be improved. That was the goal of this lung protective ventilation strategy, with a good oxygen saturation, improvement of CO2 elimination, but also by avoiding the lung injury due to the ventilator, which are barotrauma or overtrauma, tracheotrauma, or others. Next, please. While I was talking about this rationale behind the lung protective strategies, it was just to avoid these 4 measures of ventilator-induced lung injury, including biotrauma, which is due to the high pressure airways, the high tidal volume, which lead to the trauma. Both are leading our patient to have pneumothorax. The tracheotrauma, if in traditional PEEP, the alveoli will share and strain, and then later will be atelectatic. But also the biotrauma. The biotrauma is due to this stress from the machine, and then we lead to the cytokines. And remember, in the ARDS also, they talked about cytokines on the pathophysiology cases. And with this lung protective ventilation strategies, you have to think about these 4 main stages of it. The components of limited tidal volume, limited and inspiratory plateau pressure, which I was saying with audience, without having the ventilator at their settings, it may be hard to them to understand what these things means, but I think during the session, the breakout sessions will be in deep to understand at the level you can understand without having the machine around us. Also, the adequate PEEP, which is the positive and expiratory pressure, and also the limited FiO2. Patient is on 100%, but in ARDS with this lung protective ventilation strategy, a FiO2 of 100% is also bad, is toxic. So, but what can we do then to improve oxygenation, to eliminate our CO2? That will be according to settings of the machine we will have. Next, please. I was saying of the machine we will have for improving oxygenation, we have to work on high PEEP. As you find in our case, the PEEP was at 14, and some literature is saying to be even more than 20 and 24, but for a while to avoid the ventilator-associated lung injury like overextension leading to pneumothorax. Also monitoring the peak inspiratory pressure, which is reflecting the resistance and the compliance of the lung. This resistance may be from all airways, from the machine circuit and the patient's airways, which sometimes we call in dead space resistance. And this people has to be less than 40. And in some cases, you will find people limiting it in 50s to come down in alarms, but the logic or the good one has to be less than 40 centimeter water. The other good component is this plateau pressure, which is showing to us the extendability of the alveolar. And it has to be less than 30. We will understand what is it during the breakout session when we will be in the details of each of these components on this element. There is also the driving pressure. The driving pressure, which is a predictor of mortality rather than compliance and the tidal volume. This driving pressure is the difference between the plateau pressure minus the PEEP, meaning how much you are giving the pressure your patient is needing, which should not be above this range of 14 to 18. If you need more, meaning your compliance, the lung compliance we talk is less. Also, this driving pressure will also depend on how much tidal volume you are giving to the compliant lung. You see, if your compliant lung is good, you will need to have the tidal volume you will deliver will be delivered in no condition without increasing the need of increasing the driving pressure on here. So for as the parameters of oxygenating, as we had issue of oxygenation in ARDS cases, these are the parameters we have to play on. There will be another adjuvant strategies we'll discuss later, but so now there is ARDS table, which I need you to take a look. Next, please. This ARDS table, ARDS net table, is showing us how much FiO2 has to correspond with our PEEP. In our COVID treatment center, we are experiencing patients on high PEEP. Actually, we are not using a PEEP below 16, thinking of all risks. When a patient is still needing an FiO2 of 100%, as a case here, 90% without showing us a good saturation we need. The saturation we need is not 100%, but we need the range of having 88 to 95% of SpO2 or the blood gas for people who have this machine for blood gas of 55%. If you have that 55% of arterial oxygen and SpO2 of 88, so you can titrate your PEEP and FiO2 together. As you see, when you are at PEEP of 10 or 12, you should be having FiO2 in the 70s. Meaning, if you still need to increase FiO2 in 80s, it has to go together with the PEEP. This to help your alveoli to stay open. Next, please. We talked about the rationale and the goal behind these lung protective strategies. It was also for improving CO2 elimination, but also by avoiding the VILI, the ventilator-induced lung injury. Where comes to use the adequate tidal volume with 4 to 6 milliliter per kg ideal body weight. For traditional tidal volumes, they used to use 8 to 12 milliliter per kg, but with understanding of the barotrauma, the overextension, this leads us to improvement of ARDS management by decreasing the tidal volume by the low tidal volume and the high PEEP strategy in this condition. But when we are using the low tidal volume, you have to think on the CO2 retention. So for good, adequate CO2 elimination, you have again to increase your respiratory rate. Experts are recommending to start by the respiratory rate equal to the respiratory rate before intubation of the patient. So if the patient has a 40 of respiratory rate, as we used to have our COVID patient with respiratory rate of 60, 70s, you have to start with the same respiratory rate at the beginning, and then you titrate later in seconds until you reach your goal. Your goal will be to have what we are calling the permissible hypercapnia with titrated pH around 7.20. That is acceptable when you are using this kind of low tidal volume, where you may need a good minute ventilation in 40 liters. That allows as a maximum where you have to target, so that you are in a good way to say you are having an adequate CO2 elimination with a good mild acidosis, which is acceptable in the case. But with that high tidal, low tidal volume, you are having acidosis. With the high respiratory rate, we are having also the patient discomfort. You are having the breath stacking, which will lead to autopip of your patient and lead also to sorry, they are equals, which will lead also to hemodynamic instability and lead our health providers for use of vasopressors. To reduce this, you have to sedate your patient as a discomfort and paralyze them. Reason why in COVID patients, without sedation, without vasopressors, people are suffering a lot because of this kind of ventilation strategy, which could improve our patients' outcome. Next, please.
Excuse me, Dr. Xavier.
Yes.
There is a raised hand from Jean-Pierre Nitegeka. I don't know if you can respond to his question. Jean-Pierre Nitegeka has.
Okay. Raise a hand.
Yes.
Yeah, I can hear his question. Jean-Pierre? Thank you, Roberta. Jean-Pierre? The floor is at you, Jean-Pierre. It may be by default.
Okay.
Let us continue.
Fine.
So, as I was discussing, you are using your good strategies for improving your CO2 elimination and your oxygen delivery to the tissue with the goal and the settings you need. It comes sometimes you are not meeting your oxygenation need, as in a case you have patients on FiO2 of 100, people of 20. So what have to do in such case? You cannot oxygenate your patient. Again, refer to the ARDS net as I showed. revise your lung protective ventilation strategies, again, according to tidal volume with the PIP. Do some recruitment maneuver in seconds, not for a long time. There are some experts saying even the PIP can be in 30-35 for a second to 30 seconds, and you see the improvement you will have. You can position the patients. There is the well-known proning position these times, but to my experience, it works for a while. And when we turn back, it goes back too. Also, you can think about the paralysis, as I said, and also you can use the inhaled vasodilators, because with this inflammatory process, you will have the pulmonary vessels vasoconstriction, which will lead your heart also to pump against pressure, and the heart will be failure, and you have a viscous cycle, which will lead in the shock and dying of the patients. Where it's possible, they have ECMO, this extracorporeal membrane oxygenation, but in our settings, we don't have ABG machines. I don't think you can have these ECMOs. Other thing, when as a patient is on the ventilator and you fail to oxygenate him or to improve his oxygenation, you have to think with this mnemonic of DOPS and you manage accordingly. The tube may be out, may not be in the right place. It may be obstruction, mucus plugs, whatever. This, as a nurse, as a doctor, you have to do suction, irregular suction, but also have to think on pneumothorax because you are using the high PIP, so which are causing of extension of the alveoli. Also, the patient may be in pain, so give a good analgesia. You can have equipment failure, some machine or some oxygen sources or the ventilator machine can be not functioning well. The S is for the stacking, the stiff lung or the stack breath. All those things can impair your oxygenation. So to improve them, you have to think on those and then try to address one by one. Again, you want to improve your oxygenation, to improve an outcome, you have to think on some adjuvant therapy. Prof. Pore in introduction said that there is a reduction of the surfactants in the lung with ARDS and COVID, of course. You can use surfactants. This is now controversial. We are using steroids so that to be against those inflammatory reactions. To this day, we are the country since this week, we are having the interleukin 6 receptor inhibitor, which is expensive. Behind this also, you can introduce some other drugs which are acting on the cytokine storm. Think to give the fluid to your patients and also with monitoring urine output because you can overload him, and then overloading a patient also will impair to your ventilation as you are increasing the pressure to the patient on addition to what you are using. So you have to think also on the cause of this reading ARDS, either COVID or other source, other causes discussed. And after this, you judge and you see, you follow up the result of the management you are dealing with. Next, please. Thanks for the audience. The floor is back to Prof. And
thank you very much. Thank you very much.
Yeah, questions will be answered in break sessions on the talk.
You're right. So now we are preparing, Alana, we are preparing for the breakout session. I've made a small comment in the chat. You can see it. Thank you, Francois, for the DOP. This just adding a small ARA, which stands for rigidity, which sometimes happen when we give a high dose of fentanyl in ICU. Patients have that chest rigidity, stiffness, and it end up by causing some difficulty to ventilate. Also, E can stand for electricity. You remember that story of the bed 5 ICU, where the patient, whoever patient was put on bed 5 had to die every morning at 6:30 because every morning at 6:30 they will find the patient is dead. Now they put cameras in ICU and they realized that when the cleaners come to work, there was a cleaner who used to come at 6:20 and she plugged her phone. She disconnect and plug her phone. And then she was disconnecting the vent to plug her phone for charging so that the patient will stop breathing and die. So that is the story of electricity and ventilator. Bed 5 in ICU will die because of electricity. So Alana, let us go in the breakout session. Don't forget bed 5 patient. You will die at 6:30 because of electricity. Don't discharge, don't disconnect anything plugged in ICU. First ask to the expert. They'll give you why this is plugged and what to unplug and where and how. Alana, are you preparing the breakout session?
Yes, we're ready to go. Each of them 10 minutes. So the rooms will open in just a moment.
Hello, we are back again in our room for the end of the session. Alana, can you please share the slide again? Okay, that was the last slide. Let us do a double check to see if we absorb some of the expected learning objectives. I think we can all say that we defined respiratory failure. We also went through some different types of respiratory failure. And we define hypoxemia and using a pulse oximeter and also using the blood gas. We made some calculation about the PF ratio. Also, we went through the 4 criteria to define ARDS in Berlin definition. And also we saw the implication of the Kigali modification. We also hear from Jackson about some consideration from COVID patients, what changed with the definition. And then we went into the management of ARDS. So it has been long. It took more than 2 hours. We apologize for that. We hope you absorb something and you learn, you have some key points you've taken from this lesson, which will change your practice to save life. If any comment, please feel free to use the chat or unmute and ask the question before we close.
For me, a little bit to come red. I am seeing that to decide on intubation, we need to calculate the PaO2 ratio over FiO2 to determine if the patient is needing intubation by classifying the severity of hypoxemia. But in the other settings, maybe someone will be basing on clinical status and the SpO2. But how can you do approach to decide on intubation?
So that's where we discuss about using Berlin and also the Kigali modification. So you don't have the benefit of the Kigali modification is that even people without ABG machine can estimate what is the hypoxic ratio. Can you see my screen?
Yes.
Yes.
So if you see my screen, you can see that it is easier to estimate your level of PaO2 and also your level of IFiO2 by just using the tool you have. Suppose your patient is using this mask, normal mask. They are telling you the FiO2 is around 40 to 60 and is saturating 90. So 90 is equivalent, if you go to the red to the line, to 60. So the PaO2 is 60 when the SpO2 is 90. So if you are having an FiO2 of 40 or 50 and an SpO2 of 90, either you can estimate the PaO2, which is 60, divide by 50 of the FiO2, which will give you 110, something like that. Or you go straight with the SpO2, which is 90, divide by your estimated SpO2, which is 50, and you have your SpO2 over FiO2. So it's not an exact calculation, it is an estimation. You estimate that my hypoxia is severe or mild or moderate. The same if you are using another device like this one. If your patient is depending on this device, which the flow is 10 to 15, the FiO2 is around 80. It is very high, but still saturating even 95. You know, it is very hypoxic. So it's not about making a right calculation. It's about estimating the level of hypoxemia. I think for those who have followed some of the questions of those concepts before, you can just understand it's not a calculation, it's an estimation. So I think there is a lot to learn from the sessions, and we invite you for the next session. It is time to pass over the microphone and close this session. Thank you very much for those who followed until the end, and we hope to be again together next month. Alana, the floor is yours.
Thank you.
Alana? So if she can't pick up, oh, she's coming back.
Yes, sorry, just to wrap up, the link to receive the certificate for attending today's session is in the chat. It will also be emailed to you. You're also invited to check out the Learning Resource Center for slides, recordings, additional resources, quizzes, and videos. You are also welcome to join our WhatsApp group by scanning the QR code on the screen. I will share the link in the chat in a moment. And then finally, we invite you to attend our next session next month, and details will be shared on that as well. Thank you for attending today.
Bye-bye.